Very warm greetings to all of you. I'll be covering the perfect technique. Let's see how perfect is this. So, for last 3,000 years, we have seen that pterygium has troubled the doctors, the ophthalmologists. There are more than 50 surgical techniques which are described, and there are more than 1,500 peer-reviewed articles about the pterygium. But still, there is no consensus that which technique is best for which type of pterygium. S- in 2008, Dr. Lawrence Hurst he came with a technique which he termed as perfect technique. Now, what is perfect? Perfect is pterygium extended removal followed by extended conjunctival transplant. Now, what this technique is? Now, let's see. This is a small animated video for this. Incision is given at the limbus, and the corneal part of the pterygium is removed. Then an extensive dissection is done of the conjunctiva and tenons, and the muscle on the side of the pterygium is hooked, and that is pulled. And then there is extensive removal of conjunctiva and tenon tissue is done till the medial canthus. Now, the proposed this technique basically the why this technique is theoretically successful is because the pathology of the recurrence of the pterygium lies in the tenon's tissue. If any amount of tenon tissue is left closer to the limbus and even till the muscle, then that will cause a recurrence. So, in this technique, after this is done, a conjunctival graft is taken, a large one, and that is transplanted over that area, and you can suture it or you can glue it. This is now in a patient. Now, same thing, you demarcate the pterygium at the limbus, and also you mark your areas till where you want to excise the pterygium. Now, at the limbus, you just cut the part, you split the pterygium into two parts, and then you can either avulse off the part which is overlying the cornea, and you remove that part, or you can do a fine dissection in one plane so that there is not much of irregularities over the cornea left. So this the after the corneal part of pterygium is excised. Uh, it should be nicely excised. No part of the pterygium should be left. Then you do a blunt dissection and you open up the tenon's capsule, and you do a blunt dissection posteriorly over the muscle. Once you have done this, you can see now tenons and conjunctiva are separated. Then you hook the muscle. You have to pull it nicely anteriorly. So you can see the muscle is now hooked, and then you do a further dissection beyond that. Normally, in conjunctival autograft, we do say 5 to 6 millimeter of conjunctival transplant. Here we go around 12 to 14 millimeters. So there the entire tissue, the subtenon tissue, the conjunctiva, all that part is thoroughly removed so that no fibrotic tissue is left behind. So once you have done it, then you prepare your conjunctival transplant accordingly, and after cutting your transplant, so that is transferred. You can use glue. Here we have put the glue at the base. But for the posterior part, what I do is, at least in the posterior part, I put three sutures, because if it gets dislocated from the posterior part, you may have to hook the muscle again to reach the other part of the conjunctiva. So posteriorly, I put three sutures. Rest of the part you don't require to put anything. You can use the glue. Otherwise, if you want to put another two sutures at the limbus to fix the graft, you can do that. So this is after the completion of the surgery. It was a recurrent pterygium with a huge fleshy mass. So this is after the surgery on the table. So why this technique? Now, as I told, it was in 2008. 250 patients were described with primary pterygia. They were followed up for 1 year. There was zero recurrence and excellent cosmosis. Then in 2009, 111 patients with recurrent pterygia, they were followed up for 1 year. zero recurrence, excellent cosmesis. Then in 2012, there were 1,000 patients with primary and recurrent teratology who were followed up for more than 1 year. There was one case which had recurrence. Rest of the cases were absolutely normal and excellent cosmesis. And in 2020, now there are 10 years, the patients have undergone 10 years follow up, and 1,000 patients with primary and recurrent teratology, zero recurrence and no cosmesis. So, has it addressed the problem of recurrence of pterygia? Yes, as per the studies published in the literature, more than 1,000 patients followed up for for 10 years with zero recurrence in so many patients, and cosmetically the results are excellent. If you compare to other techniques, as Dr. Praful had pointed out, the recurrence rate with other techniques, here in one subset of patients, there was only one patient who had a recurrence. Rest around 2,500 to 3,000 patients, there was no recurrence overall. So, is this perfect? No. What are the disadvantages of perfect surgery? Now, this is a lengthy procedure compared to a normal conjunctival autograft. You need a meticulous tissue handling. You may have patient may have transient diplopia because you're doing the muscle handling, and also there may be some post-operative pain. But the other part is it a step closer to perfect pterygium surgery as there is no recurrence and better cosmesis? Yes. With this I finish. I have around now 35 to 40 cases which I've done with this technique, but I normally select the cases which have got extensive fibrosis, which have multiple recurrences. In those cases it's working well and I had no recurrence till now. Thank you. Sutures you can remove after about say 2 or 3 weeks. Once you see that the graft is well taken, then you can remove. Now you can do that. Only thing is here, yes, yes, absolutely. You can remove the sutures as early as possible. There are no recommendation for that. There are no recommendations for removal of sutures. It's up to you. If the Yes, you can remove that. Even if you don't put a suture, that is also okay. His patient is ready for undergoing a second surgery in case required. That suture we have kept only because we are going quite posterior. Maybe now that part where you are putting the sutures and the posterior part of the pterygium where you are applying the sutures, that may not be visible. So if you have to redo the surgery, you may require to hook the muscle again. That is the only reason. Otherwise, you can just go get away with the glue. Glue normally holds.
So,
Glue normally holds.
actually, in the traditional perfect technique that has been described, glue has not been used, only sutures are used. The reason being it's such a large graft that you're going literally up to the medial canthus and up to the superior rectus, superiorly and inferior rectus. So, it's a very large graft. There are more chances of it getting dislodged, especially posteriorly, as he rightly said. So, in the traditional technique, no glue has been used, sutures have been used. But yes, of course, we can modify the technique depending on our comfort level and our experience. We can put a few sutures, maybe remove them early, put a large bandage contact lens.
Yes. No, no, no problems. It's up to your choice. You have to select out the individual's choice whether the patient can pay for the glue or you feel more comfortable with the sutures. So entirely your perspective depending upon the patient. Yes. See, some amount of inflammation because that part is conjunctiva and subconjunctiva is already inflamed, and there may be thick scarring which is holding the two things. So, uh, I think should be avoided because here you are taking up a case which is undergoing a recurrent area and already there must be a lot of fibrosis. So, better to